So, good evening. I'm Warren Hammert, and on behalf of the American Association for Hand Surgery, I'd like to welcome everybody to our webinar. This is the first one in this series for the year. I'm going to turn the panel over to Dr. Glenn Gaston from Charlotte, North Carolina, who's going to be our moderator and lead this webinar. Glenn?
Thanks, Warren. And thanks to all of you that were able to join. We look forward to it. This was a second year we've been doing this. Last year was the inaugural year, and it was really well received. So a little background about this series. One of the great perks about being on this call is, I think hopefully you all know, is that there are 3 webinars this year that are geared directly towards APPs. And if you attend 2 of these 3 webinars, then you will have a 1-year complimentary membership in AAHS. It's sponsored by Endo. And so if you attend 2 of these 3, those are the other dates you can see there, July 15th and August 19th. And once you're a member for a full year, you get all the regular membership benefits. So there's a ton of opportunities there. You get a big discount to come to the annual meeting, free partner guest and child registration. And so for tonight's webinar, we've got 3 outstanding speakers. Noah Raizman, Mihir Desai, and Micayla Zeltman are all 3 going to give great talks. And then Warren and I are going to be here to field the questions for them towards the end. So any questions that arise during this, put those into the chat. And what we'll do is at the end of everything, we will field the questions. We may field one in between each talk, but we'll definitely field them all at the end. So the future webinars, again, July 15th will be in-office procedures that you as an APP can perform and how to code that appropriately. And then the August 19th will be an endo program about the opportunity to use collagenase as providers. And APPs are using that as well as the primary administrator. So they'll talk about that a little bit as well. And if you haven't done so already, but you're thinking about it, this year's meeting, it's always in phenomenal places for AHS, and this year is going to be no different. So the 2026 meeting, you can see is that weekend of January 13th to 17th. It'll be in California at this lovely venue. So we look forward to tonight, and I'm going to turn it over now to Micayla to give our first talk.
Hi, everyone. Can everyone see my screen?
Yep, looks great.
Perfect. Okay. Thank you so much for having me. I have no disclosures tonight, except that I really love my team, so be prepared to get bombarded with a ton of photos from them. So a little bit about me and why in-office diagnostics are really important to me. I'm a hand and upper extremity physician assistant at The Ohio State University. I am clinical and surgical. So I spend 3 days doing full independent clinics on my own, and then 2 days plus or minus a half day of procedures in the OR. And we have a really diverse patient population. So we're a true combined orthopedic plastic surgery practice. And my clinic is comprised of new patients, return patients, and post-op patients. So it's really important that I am accurate and efficient in my diagnostic techniques. So the way that I like to break this down and the way that I'm going to start the presentation is with more broad concepts in order to help you as an APP develop your gut instinct and develop really good systematic approaches to things like your interview and your physical exam. And then develop ways that you can seek feedback on your diagnoses and your physical exam techniques so that you can become confident and more experienced in your techniques. So while it's going to be a little bit more broad, we will talk about some cases as we go through. So we've all been there. It's 11:50 in the end of the morning. It's your last patient. The only thing that stands between you and lunch is this new patient on your clinic. All it says is wrist pain. You're like, okay, great. You scour the chart. There's no notes. There's no other physician referrals. There's no imaging. There's nothing. It just says wrist pain. So you're automatically annoyed, right? You're starving, your brain is tired, you're thinking, why on earth do I have this in my template? I should just change my template so that I have a nice simple return patient at 11:50. So it's very easy at this point in time to kind of panic and get stressed and anxious and freak out about things. And I don't want that at all. I want us to stop, take a deep breath, focus on the ways that we can systematically approach this type of patient so that we can have good, accurate, efficient diagnosis techniques. So the first way that we can start with this is by making a systemic approach to the patient interview. I know that we're all taught in school that we need to have really open-ended questions, but I myself don't ever walk into a patient's room and say, "Tell me what brings you in today." While that might give us some really good information, oftentimes that's going to lead to a 10-minute discussion about great Aunt Sally's gout that she had 2 years ago, or maybe your cousin's tennis elbow, things that aren't pertinent. So we can still have really good rapport with the patient while having focused questioning that leads us to really good exams. So for example, for the 1150 patient came in with wrist pain, I go through each question of old carts in my interview skills. So the wrist pain that brought you in today, the wrist pain that made you sign up to come to an appointment today, when did that start? Point with one finger to exactly where it's located. When it happens, is it short? Does it last a long time? Can you describe this pain for me? And be specific with that. And I encourage you to listen to the adjectives that the patients tell you. You can learn a lot by how they describe something. Are they saying sharp and stabbing pain, dull and aching? Is it burning? You can start to think just by their adjectives. Okay, are we dealing with muscle, bone, tendon, nerve? You can really get a lot just by listening to them. Ask them specifically about this condition. What makes this worse? Is there anything that you have done that has tried that made it better? Is it at night or is it at the morning or does it happen throughout the day? And on a scale of 1 to 10, what's the severity of your symptoms? So we can have the most systematic approach to a patient interview, and it means nothing if we can't do a proper physical exam. And that proper physical exam cannot be done if you don't understand normal anatomy. No pun intended, but you need to understand anatomy like the back of your hand. I did my training at Elon University, and we were really big on body painting. No, I'm not saying that I paint my arm right now to understand the anatomy, but this is a way that my brain visualizes the patient every time that I am doing a physical exam. I have drawn on my arm and I have contracted the muscle as I'm learning the exam technique, so I understand exactly what it's doing. Whatever you need to do so that your physical exam becomes second nature to you and you don't have to really think about it, whatever builds that brain connection is going to be really important in developing a systematic approach to your physical exam. And when you do that physical exam, practice on yourself. You're very fortunate that you have 2 arms, so you can practice on yourself. When you practice on yourself, do it the exact same way every single time. In my clinic, if I have a patient that's coming in with ulnar-sided wrist pain, I have a template that I have on my in my dot phrase that I will pull up right alongside the patient, and it goes through systematically every single thing that I need to look at so that I don't get lost in the conversation and I don't miss anything that's really pertinent. So for this patient, if they came in with that 1150 patient, if they came in with radial sided wrist pain, I know that I'm starting first with inspection. I'm looking at the skin. Are there any scars that show that they've had surgery in the past? Is there any atrophy that I'm worried about? Do they have any deformity in regards to the position of their thumb or their wrist? Then I'm going directly into palpation. I'm palpating tendons, ligaments, looking for tunnels over nerves that are in that area. And then I'm doing any special tests that are involved. And we'll go into some more specifics and into what that could look like for you. Once I have a really good systematic interview, which leads to a systematic, tailored, focused exam, then I can seek feedback on the differential diagnosis that I've created with appropriate imaging. And so it's really important that you understand what imaging to order when you're looking for specific diagnoses. And you do that based on the differential diagnosis that you've created with your intentional exam techniques. It's also really important that you develop a systematic interpretation of those imaging. So with X-ray, I always start outside in. So I start looking at all of the soft tissues, then I transition into bone, then I transition into alignment of structures. For MRIs, I always pull an MRI up in 3 views. Same with a CT scan. I want to look at an axial, sagittal view, and I want to really develop a 3D picture of what's going on in my head so that I can fully understand what's happening. And I do the same process that I do with an X-ray. I start with the outside in, soft tissues, bone structures, ligaments, alignment. And then again, understanding special images in relation to special testing is really important to become efficient in your in-office diagnoses. So let's say, for example, the 1150 patient that came in was a 70-year-old female that had aching pain at the thumb CMC joint without injury. It's worse with gripping. On exam, you note grinding. What type of imaging do you want? You don't just want a whole hand x-ray. You want specifically a thumb x-ray. And special views, you want a Roberts view. And this view is going to get you a dedicated, true view of the thumb CMC joint. So you can make a proper, accurate diagnosis in regards to the severity of CMC arthritis that you see on that patient, so that you're able to fully present accurate treatment options for that patient. Now, let's say this 1150 patient was a 45-year-old male who had burning pain at the radial wrist with healed wounds from a laceration 5 years ago. On exam, you checked nerves as well as muscles, tendons, bones, and you find that there's a tunnels right where radial sensory nerve is going to be. That's a really good opportunity for an ultrasound that you can order. So you can ask for the nerve, the radial sensory nerve, to be traced through specifically to look for something like an aroma. Let's say that 1150 patient was a 23-year-old who had stabbing pain at the anatomical snuff box after a fall. You want to order specific wrist x-rays. You're not going to order a whole hand x-ray or a forearm x-ray because you've done a really good, proper exam already. And specifically, you want to look for a scaphoid view. So let's say you get an x-ray like this. You're like, well, he's really tender at that scaphoid. I've done a really good job with my exam. I'm trusting my gut. I just am worried about that scaphoid. Well, then you think, do I need to do serial imaging or do I need to do advanced imaging? What I will do in my practice is, if I'm really worried about something like this, I trust my gut, I'm worried that there's a scaphoid, the mechanism's accurate, I will treat it like a fracture. So I'll immobilize the patient, bring them back in 7 to 10 days. I'll do repeat x-rays at that time. If I see something like a scaphoid fracture, great, we can treat it that way. But let's say I don't see something like a scaphoid fracture and we're back at the same square root where we have, hardly any evidence of anything on an x-ray. Trust your gut and repeat your physical exam. Never be afraid to redo your physical exam so that you can make sure that you're ordering the most appropriate imaging. If they're still really tender, get advanced imaging, get a CT scan, specifically if you're looking for bony pathology. Now, let's say this is an 18-year-old male with constant dull aching pain at the SL interval. He had a fall 1 week ago. You're looking specific at the wrist because there's tenderness at the SL interval. But specifically in this situation, I would order bilateral pencil grip view. If I'm worried that there's pain directly over an SL interval and it was an acute mechanism, I want to see, is there an injury to SL? And the best way that we can compare injuries or see if there's a true injury to an SL is to look at the other side so that we understand what normal is. Some people have anatomy that isn't necessarily a narrow SL, and so it can look widened. So a bilateral pencil grip view is going to give you the most accurate information. And then if you're still questioning something at that point in time, that's when you can consider advanced imaging. If you definitively have an SL tear, then you can get advanced imaging for surgical planning. But if there's still tenderness in that area, think zebras sometimes. Is there an occult ganglion cyst? Is there Kienbach's disease? Advanced imaging will help provide you the most accurate diagnosis. Some tips and tricks that I have found in my practice to help with understanding and ordering advanced imaging is to scout my clinics ahead of time. There's nothing worse than walking into a patient's room feeling like you don't know what's going on, especially when you have complicated advanced imaging. So dedicate time to review those images on your own, without the stress of clinic, without the stress of people around you asking you a million questions, so that you can dedicate time to come up with the appropriate diagnosis and develop a plan. I also think it's really important to review your physical exam findings and review the images independently of the report. We can get really lost and skewed into what a radiologist will tell us on a report. And while I appreciate everything that they're doing for us, we need to develop our own internal gestalt and develop our own diagnostic skills. And we do that by independent interpretation. It's also really helpful to pull up the images while you're examining a patient. As you get more and more comfortable with exams and diagnoses, you might need to order less and less imaging, and you do that because of the reinforcement that you get from imaging that you've ordered in correlation with a good patient exam. Another thing that I do is, if you find a great example of normal or abnormal on patient imaging, save that and use that as a reference point for other images that you've obtained in the future If you're really questioning, is that an SL tear? Is that a UCL tear? I can't really tell. If you have good examples of normal or abnormal in the past, it's great to compare. And then, like I said before, always use 3 views of advanced imaging to build a 3D view of anything that you're looking at. And this is just an example of what I do when I pull up an MRI for any patient that I have. So let's say you do a perfect systematic interview, perfect systematic exam, you get great images, and something is still a little bit off. So let's say that 1150 patient was a 45-year-old female with radial-sided wrist pain. There's positive grinding on her exam, but there's also a positive Finkelstein's test. X-rays with a Roberts view show mild TMC arthritis, and you're just like, what is going on? Like nothing is very, very obvious at this point in time. This is where diagnostic injections can be really helpful. Trust that you have developed a very good differential diagnosis, and then you can use diagnostic injections to help you come up with a confirmed diagnosis. So based on that patient's exam, you can either decide to inject into something like the CMC joint or into the first dorsal compartment, have the patient monitor their symptoms and report back. If they didn't get any relief with the first injection, 6 weeks later, you can try another injection in a different location, and you can help definitively come up with better ways to diagnose patients intraoperatively or in the office. Another thing that I really love to do is seek feedback from my exams and or imaging when I'm in the operating room. I recognize that not every APP has the luxury of being able to go to the operating room, especially on patients that they've seen and worked up independently. But here at Ohio State, we really get to do, and it's wonderful because if I have a complicated fracture or I have, I don't know, a UCL, this is an example of a patient's schwannoma that we took out a couple of weeks ago. I can examine the patient, correlate those exam findings with the imaging that I've decided to obtain, and then I can see that intraoperatively. And then afterwards, I go back and I re-review those images so that I can really develop a good, thorough understanding so that my in-office diagnostic skills are more succinct and efficient in the future. And then also, when in doubt, dissect it out. We're also really lucky that we are at a place where we have the opportunity to work with cadavers on a regular basis. So keep in mind things that are confusing to you when you are doing a physical exam or when you are dissecting something in the OR, and really use any opportunity that you can in a cadaver lab to practice techniques. You can also practice techniques on your peers and your colleagues. Ask them how they do something. Ask them to show you how they do a physical exam maneuver. Ask them if you can practice your maneuvers on them. And then also stay engaged. You're here tonight, so clearly you want to learn. You want to be involved in bettering yourself and bettering your diagnostic skills. Sometimes just hearing something differently can help change the way that your brain thinks or develop a new pattern in your head to be more efficient in your diagnostic skills. So always talk to people, learn, and don't be afraid to ask questions. So in summary, enhancing your diagnostic skills starts outside with an understanding of your anatomy and before the exam with a focus interview. Look for ways to get feedback on your skills. That can be imaging, injections in the operating room, labs, peers, which will build your confidence and ultimately improve your efficiency. And then in all that you do, develop a systematic approach. Thank you.
Thanks, Micayla. That was outstanding. Next, we'll have Mihir Desai from Vanderbilt, who's going to give us a similar talk from a surgeon's perspective, and then we'll finish up with Dr. Raizman at the end on the coding pearls for everybody. And again, if you have any questions, feel free to enter them into the chat, and we'll address those at the end of the webinar.
All right. Hopefully everybody can see that okay.
Looks great.
All right. Thank you, Hand Association, and as well as everybody who's attending. I think this is a fantastic opportunity to highlight some things that can really make your practice more efficient and certainly deliver better patient care. So I'm going to switch gears just a little bit and talk about things that are a little bit more focused clinically and highlight some physical exam and imaging pearls with some clinical examples of a few very common things that we might see. These are my disclosures. None of them are really pertinent to this talk. So we'll dive right in. So we'll start with patient CP. This is a patient that I'm pretty sure we've all seen in our clinic. Young baseball player coming in with 2 weeks of finger pain after fielding a ball. Clinical exam is similar to this with a swollen PIP and some limited range of motion. This patient's not coming in directly after the injury. They're coming in 2 weeks after, or sometimes even later. And when we work these patients up, it's important to sort of understand the spectrum of injury that these patients can sustain. When you look at a patient that's got an exam like this, a stiff, swollen PIP, the clinical picture and the clinical diagnosis could span the entire spectrum of something as simple as a PIP strain all the way to a very complicated fracture. Oftentimes, the imaging will be normal, or it could look something like this with a small volar plate avulsion injury with a stable appearing PIP. To manage a patient with this clinical presentation, something as simple as body straps and therapy can go a long way. Contrast that with an image that looks like this. So the fracture's slightly larger. But what's really important to recognize here is this classic V sign that we see within the PIP. You have a little bit of that dorsal subluxation of the middle phalanx over the head of the proximal phalanx. And this becomes an entirely different animal compared to the previous image. In the previous image, counseling the patient, giving them reassurance, and really waiting it out several months will largely get the patient through that trauma. But with an injury like this, with a high rate of arthrosis and limited range of motion, they might require a surgical intervention. And so being able to recognize that patient as somebody who's not going to do well with just simple non-surgical management, they're going to need something a little bit more involved, such as something like this with a volar buttress plate for that fracture. And just a couple radiographs to show what that would look like. Now, another fairly common presentation that we see is the ulnar wrist pain patient. So this is another patient, 35-year-old or 34-year-old with right wrist pain, off and on for the past few years. Hopefully they're not coming in at 11:50 a.m. before lunch, but this is a patient that has had acutely worsening symptoms over the past 3 months after a minor fall, and their exam right off the bat, they're tender and they indicate that most of their pain is at the ulnar wrist. They have pain with any forearm rotation or carrying heavy objects. What's important to recognize with the ulnar-sided wrist pain, and I think if you take care of any of these patients in clinic, you recognize that they are the low back pain for hand and upper extremity specialists. And having a nice algorithm, really talk where she talked about her algorithm for working patients up. I think that rings very true for patients with ulnar-sided wrist pain, because the variety of diagnoses that can lead to that presentation is vast, and it's important to understand the subtle nuances of the physical exam, and as well as the right diagnosis and eventually the right treatment. So briefly, I'm not going to cover the extensive anatomy of the DREJ, but it's important to understand just how complex this part of the wrist is and why it's susceptible to being a pain generator and the variety of things that can cause that pain. The DREJ and the relationship between the radius and the ulna at the sigmoid notch is largely held together by soft tissues. There is some minor constraint with the bony anatomy. So really any sort of bony abnormality or any soft tissue abnormality can lead to malalignment or poor function in this part of the wrist, and that will inevitably lead to pain and discomfort. And so any area around this part of the wrist can become a pain generator and a reason for the patient coming in to see us for that ulnar-sided wrist pain complaint. There are several diagnoses that come to mind. If patients have a history of an intra-articular distal radius fracture or an injury to the distal ulna, those fractures can cause the ulnar-sided wrist pain. TFCC injuries will be probably the most common reason that we're seeing ulnar-sided wrist pain. And these can be traumatic or degenerative. I think in most of our practices, we'll see the more degenerative injuries. And this could be from acquired or idiopathic positive ulnar variants, which we'll kind of highlight here in a second. And then another diagnosis that we need to look out for is ulnar impaction syndrome. We can also have dislocations of the DREJ, and this can be acute or these can be chronic, as can be seen in these images here with a mad lung deformity of the distal radius. Patients can present with arthritis and also ECU, tendinopathy or instability. And then things like tumors, synovitis, gout, pseudo-gout, those kinds of things can also lead to pain, dysfunction, and that ulnar-sided wrist pain complaint. So how do we work these up? Again, it starts with a very solid, thorough physical exam, inspecting for any swelling, bruising, open wounds, anything that would indicate any direct trauma. Certainly palpating to localize the tenderness. I think this is extremely valuable when working these patients up to really ensure that we're not where you're finding the surface anatomy and understanding exactly what you're palpating can be very helpful. Stressing individual joints and any attempt to reproduce the symptoms. So reproducible physical exam tests that can elicit the pain can be helpful. Measuring grip and pinch strength if you're following these patients over time. And then the one thing that oftentimes we forget is, if the patient's got a healthy contralateral wrist, use that to help get a comparison exam. Sometimes just an exam on the contralateral will really make evident what the patient's dealing with. So these are a few of the provocative tests that we use for the ulnar side of the wrist, including the piano key test, the pisiform boost test, which can look at ulnar carpal impingement, ulnar compression test, ulnar grind test, which all really give you an idea of either compressing across the DREJ or compressing between the ulna and the ulnar carpus. Pisotriquetral grind test, which is eliciting or pain with grind over the pisotriquetral joint. Tenderness along the FCU, ECU, resisting wrist and flexion and extension, as well as finding a foveal sign. Foveal sign is going to be a classic finding for the TFCC. It's going to be the tenderness located right in that soft spot, just distal to the distal ulna, and is fairly sensitive for picking up on subtle TFCC pathology or intra-articular synovitic changes. In my practice, I think going through all of these is fairly involved. So I think pick a few different tests that work for each of the variety of diagnoses. For me, it's going to come down to inspecting, palpating. And then if I am worried about somebody having something like ulnar impaction syndrome, I'll do an ulnar compression test or ulnar grind test. And then if you're worried about DREJ arthritis, grind across the DREJ can be really helpful. But I think eliciting tenderness in this area and really pinpointing exactly where the patient is tender can be very helpful. Ultimately, we will order diagnostic studies for these patients. And I think the most common ones that we're going to start with the simple ones like plain radiographs and work our way up along the diagnostic ladder. As far as looking at the ulnar side of the wrist, it's important to understand ulnar variants, especially how that might change as patients rotate. So remember, ulnar variants will change with forearm rotation. So with the forearm supinated, you'll have slightly less positive ulnar variants compared to pronation, where the radius is rotating over the fixed ulna, and the ulnar variants can be accentuated or increased. Pronated grip views can stress the distal ulnar joint, and that's a nice way of getting a stress view to evaluate for ulnar variants and see if they have any dynamic impaction. But if you look at certain studies and you only use certain studies, you may see that there may be some subtle differences in how you're measuring the ulnar variance if you just stick to certain studies. So if I have a patient with ulnar-sided wrist pain and I'm really worried about that ulnar impaction diagnosis, we'll get some neutral rotation x-rays as well as a pronated grip view to see how much dynamic motion we're seeing across the DREJ. This is what a bilateral pronated grip view looks like. And this is a pronated view because you can see that the ulnar styloid is not parallel to the radial styloid. So this tells you that the radial ulna and gives you this kind of stress view of the ulnar impaction area. MRI is also very helpful in diagnosing these patients, especially with that diagnosis of ulnar impaction syndrome. You'll sometimes see this classic edema on the T2 sequence of your MRI, and you'll see that edema within the lunate. And that's just a telltale sign of the constant repetitive impaction of the distal ulna against the lunate that's causing. You'll also oftentimes see central TFCC tears present or show up on these MRIs as well. And really, most of our patients that have those central TFCC tears, they probably do have an of ulnar impaction and that dynamic ulnar impaction that's causing those tears. So that's something that you'll see on these MRIs that can be very classic. So for this patient, they were ultimately treated with an ulnar shortening osteotomy to level the joint and relieve the pressure that they were experiencing across their ulnar wrist. Well, how about patient AW? So this is another fairly common presentation or common complaint that we'll see. 74-year-old female referred by their PCP for ring finger triggering. They do have a medical history of RA that's been treated with some disease modifying agents, and it seems to be controlling the disease. On the physical exam, the ring finger's locking in flexion, pops into extension. They've got a slight extensor lag to their ring finger, and interestingly, have no tenderness to palpation over the A1 pulley. The reason I put this case in here is I think a lot of us at face value, when you see on your Epic clinic list, the patient's chief complaint is triggering, or the PCP refers them to triggering, we're automatically going to think that the patient's coming in to see us for trigger finger. But it's important to also think about some other reasons why they may be having this clinical presentation. In this patient, with this history of RA, they actually may present with some tendon subluxation of their extensor tendons over the MCP. And that can lead to a very similar clinical presentation as trigger finger. So it's important when you're evaluating a patient with trigger finger, just flip the hands over and look at the dorsum of the hand and just make sure that there's no tendon subluxation. I would say after you've seen a couple of these patients, you'll notice that they do present differently than trigger finger. They don't exactly have the exact presentation as somebody with a classic trigger finger at the A1 pulley. But if you just get into the habit of turning the hand over, looking at the dorsum of the hand, and just making sure that you're not missing some tendon subluxation. Certainly, and I think if you've been doing this long enough, you'll see patients that come into clinic that have had a couple injections and haven't really helped with their triggering of their trigger finger, and then you turn their hand over and you notice that it's actually the wrong diagnosis. They actually have this diagnosis, the extensor tendon subluxation. So obviously, we know that this is can be treated very differently. So thinking through the physical exam for these patients, we want to make sure the extensor tendons are in continuity. So, palpate across the dorsal wrist, across the extensor tendons. And we can also capitalize on the tenodesis effect. This is going to be a very powerful tool to diagnose somebody who has some sort of extensor tendon disruption or flexor tendon disruption. But just remember, with the tenodesis effect, passive wrist flexion will result in finger extension. Passive wrist flexion will result in finger flexion. Excuse me, I said that backwards. So passive wrist flexion, finger extension, passive wrist extension, finger flexion. And you want to witness all of the fingers going through that nice natural tenodesis and that cadence of flexion extension. And this can also be really helpful in differentiating between a nerve problem or a tendon problem. If you have a patient with a diagnosis of RA, for example, who comes in with a loss of finger extension, that could either be related to a rupture of the extensor tendons across the wrist, or that could be related to and synovitic changes around the radiocapitellar joint causing a PIN palsy. Well, it's important to understand where the tenodesis effect can come into play to allow us to test for that, so that that you're coming to the correct diagnosis. So with this particular patient, we diagnosed them with extensor tendon subluxation, not a trigger finger, so an injection at the A1 pulley is not going to be helpful. And for most of these patients, if it's fairly acute, you can try splinting and see if you can get some stability back, or if the patient's low demand, sometimes the yoke splint can help just combat some of the symptoms they're having. But most of these patients will require some sort of centralization procedure to prevent that from continuing to subluxate. All right, so another patient, JJ, comes in. He's a collegiate baseball player. We've got another ulnar-sided wrist complaint, but this patient actually has a trauma or an inciting event. He recalls hitting the ball a little funny during batting practice, and on his exam, he's tender over his ulnar wrist. He's neurovascularly intact, but he just has this tenderness. He's unable to complete batting practice because of the pain in this area. So we get some initial imaging, and for anybody who's playing baseball, golfers who present with a complaint like this, I think we'll automatically start thinking about the hook of the hamate injury, which oftentimes isn't going to show up on a standard set of wrist X-rays. And so I just wanted to throw this in here to have an idea of what the carpal tunnel view can give us. So a properly performed carpal tunnel view can really highlight an injury like this, the hook of the hamate injury that you can see right here. This is a diagnosis that sometimes, even with a good carpal tunnel view, you can't really make it out. And sometimes we'll have to get some advanced imaging to look at these, including a CT or an MRI. But a good carpal tunnel view can arrive at that diagnosis, which really fits with that patient complaint and their history. And so for a patient like this, we elected for an excision for the hook of the hamate fracture, and he returned to play in about 4 weeks. So with that, I thank you. Certainly open to any questions you might have.
Thanks, Mihir. That was perfect. And what we'll do now is we'll transition over. You can stop sharing to here, and then we'll have Noah take over, and he's going to give you the coding portion of this. So hopefully now you've arrived at the right diagnosis, and Noah's going to teach you how to get paid for doing so.
All right. Can everybody hear me?
Perfect.
All right. Well, greetings from Washington, D.C., seat of government inefficiency and bureaucracy. And so I'm going to share with you some insight into the bureaucratic and government mandated aspects of what we do, which is coding. If there is one thing that you need to take from this as an APP, it's that you cannot hide. No matter what you think of the differentiation between physician assistant and physician associate and scope of practice issues, one thing that has happened as a result of APPs becoming more independent and that being enshrined into law is that you are no longer covered under the aegis of the surgeons you work with in terms of coding. And if you miscode, it's considered fraud, and the onus is on you. Even if you have not had any formal training in this, it is your responsibility to know and understand this. And so I think it's really important for you to take this very seriously and understand that this is really your obligation. So there are three basic types of billing when it comes to Medicare. Direct billing, which is you bill under your own NPI. You get 85% of the allowable charges. There's no requirements for physicians to be around you or to look over your shoulder, and that reimbursement is allotted directly to you. In the office setting, you have the ability to bill incident to a physician that you're working with. Now, it used to be that the physician had to be on premises, but right now, some telehealth provisions are still in effect that say the physician must be available by audio or audio-visual contact for any questions. Now, you can only do this for established patients once a plan of care exists and you are fulfilling that plan of care incident to the physician you work with. Now, the physician you work with does not need to co-sign, but it's recommended that they do. But this is reimbursed at 100%, but it comes under the billing of the physician you're working with and has to be separated out to you later. And then in facility settings, so hospitals and hospital-associated clinics, you can do split shared, and that's when you're both seeing patients together. Whoever completes the substantive portion, either by the amount of time spent or the medical decision-making, documents and bills. If the physician bills, it's billed at 100%. If the APP bills, it's billed at 85%. So when you think about the requirements for incident to billing, the plan of care has to be established. Any new problems or any time the plan of care is altered, then you have to direct bill. So you only get 85%, and it doesn't come under the aegis of your physician. Diagnostic tests generally cannot be billed incident to unless you state that there's direct supervision. And even so, certain tests like X-rays and EKGs are not subject to incident to billing. I recommend that the notes be signed by both providers, and it's helpful to acknowledge that the physician was either in the office suite present or available via real-time audio-visual communication in order to provide assistance. Now, if you're operating with a surgeon, you're always going to bill using your own NPI number, the same CPT code. Make sure your CPT codes match up. Depending on what insurance you're using, you'll either use an AS, Assistant at Surgery modifier, or an 80 or 82 modifier, which implies an assistant at surgery. Only surgeries that qualify for an assistant can be reimbursed. That information can be found through the CMS physician fee schedule. There's a large Excel spreadsheet, and it will have information on that. You generally need dictation by whoever's dictating the operative report that the case was complicated enough to require an assistant. That's typically boilerplate verbiage, and you need to document if you're in a place that has residents that no resident was available. Now, if you have a resident available and both you and the resident scrub, you can't bill. The reimbursement for an assistant is a 16% of the base surgery, but since a PA or NP only gets 85% of that, 85% of 16% is 13.6%. So that's what you make as a surgical assistant. Now, the bulk of what I'm going to talk about is E&M coding in the office. It's all about documentation. You need to use wording, establish templates that reflect the appropriate CPT language that keeps you out of trouble, provides consistency. It makes you audit-proof as best as you can be. Remember that the people looking at what you're doing, your auditors, your coders, whether they're coders associated with your practice or somebody that is auditing you from outside, they don't have a medical background. So they're checking off boxes. If you can make things obvious for them, that will allow you to escape any more scrutiny than you need. Your documentation should be unimpeachable to protect you from audits and also to maximize appropriate reimbursements. Now, overcoding is fraud. Coding for things you didn't do is fraud. You need to be aware of that. Now, you know the new patient and established patient office codes, 99202-5 for new patients and 212 through 5 for established patients. Basically, this corresponds to straightforward for level 2, low, medium, and high levels of risk and complexity. A lot of surgeons try to have their APPs do preoperative visits. This is problematic. Even though CPT defines the global period beginning 1 day before a major surgery, that's not what CMS defines it as. CMS defines it as whenever the decision for surgery has been made, and your private payers are generally going to follow suit with that. That means that in general, pre-op H&Ps are included in the global and they're not separately reimbursable. So if you're doing a lot of these to do the H&P the day before surgery, you are not going to get money for that. Now, there are situations where you can bypass this. Preoperative risk stratification may be reimbursable, but not usually by a PA that's employed by the surgeon. It is possible, and this gets into some murky territory, for a provisional decision for surgery to be made pending preoperative risk assessment, consults, labs, et cetera. And then when you come back for a final visit or a final decision for surgery, this all depends on how you document it and how you're talking about this. You need to be very careful. Now, going to the 3 components of E&M. The first category is the number of problems addressed and potential treatment options. Number 2 is the amount of information processed, and 3 is the potential associated risks of both the condition and the treatment, okay? You only need to get to a certain level on 2 out of the 3 in order to build that level, okay? So if you have moderate, high, you can bill moderate but not high. If you have low, moderate, you can bill moderate. If you have low, moderate, high, you can only bill low. So when you look at the level 2 visits, this is something that should not require a visit to a hand surgeon or orthopedic surgeon. I think generally speaking, you should be documenting your minimal level as a 3 unless you are doing a quick check-in. The patient has reached the end of their treatment course, they're happy, and they just stop in to say hi. That would be a level 2. Pretty much everything else is going to be level 3. So what are the components of a low complexity visit? So 1, the third category, the risk of additional treatment is low. You need to have multiple self-limited or minor problems, 1 stable chronic illness, or an acute uncomplicated illness or injury. And the requirements are low for the amount of data you analyze. Now, some of the definitions are unclear. Now, that can be problematic or it can be advantageous, depending on how you look at it. A self-limited problem is one that runs a definite and prescribed course, is transient in nature, and is not likely to permanently alter health status. An acute uncomplicated injury has little to no risk of mortality with treatment. Full recovery without functional impairment is expected. A problem that's normally self-limited or minor but not resolving would also qualify. The examples include a simple sprain. So again, this is stuff that should barely get to your doorway. Now, when you go to the next category, chronic illness with exacerbation progression, okay, that is a chronic illness that is either acutely worsening or it's poorly controlled or progressing and requires additional attention to manage. An undiagnosed new problem with an uncertain prognosis is likely to result in morbidity without treatment. An acute complicated injury is one that includes evaluation of multiple body systems, or the injury is extensive, or the treatment options are multiple and associated with a risk of morbidity. Now, when you get to moderate complexity, which is a level 4 visit, you're looking at 1 or more chronic illnesses with exacerbation, 1 undiagnosed new problem, or 1 acute complicated illness. Examples of risk of treatment include, but are not limited to, prescription drug management, a decision regarding a minor surgery or procedure with identified risk factors, which could be diabetes or anticoagulation, just for example, or a decision regarding an elective major surgery. When you get to the high level of complexity, we're talking about somebody you are sending to the ER directly from clinic, or sending for emergent surgery the next day. The bar is high to get to a level 5, but the bar is low to get to a level 4. If you want to bill by total time, you can do so. You need to meet the minimum criterion for each of these. So to get to a level 3 new patient visit, you need to spend a total of 25 minutes. You need 45 minutes to get to a level 4 new patient visit and 60 minutes to get to a level 5. Those numbers are smaller for established patient visits. Now, what qualifies here? It doesn't have to be face-to-face time. It can be preparing to see the patient, obtaining and separately reviewing an obtained history. You're in the room, conversation with the patient, examination and evaluation, counseling, ordering tests, referring or communicating with other healthcare professionals, not with the physician you're working with, though. That does not count. Documentation, independent interpretation of results, or care coordination, only for that day of service. So a couple pearls on how to really use the system to your advantage. If you state that the patient is not at his or her treatment goal for whether it be a trigger finger carpal tunnel or arthritis, that is chronic with exacerbation. But you need to say that the patient is not at his or her treatment goal. It needs to be clear. And when you have an acute injury and you say this condition, if left untreated or undertreated, would predictably lead to substantial morbidity or loss of function, that makes it an acute complicated injury, which gets you to moderate for that category. Now, you need to document not just prescribing medications, but prescription medication management, reviewing their current medications, looking at interactions, side effects, and the overall balance of what they're getting. And that needs to be documented in order for you to get to that moderate level for that third category. But medication management includes not just giving them a new prescription, continuing a prescription that you've reviewed, modifying the dosage, or discontinuing a prescription medication. All of those count as medication management. And probably most importantly, if you clearly say that a patient is indicated for surgery and you discussed risk benefits and alternatives and they choose to defer surgery, that is a decision regarding surgery, which gets you to the moderate level of complexity. So a couple modifiers that you're going to be using often, a 24 modifier. If you are in a global period for something and the patient says, also, I want to tell you about my contralateral wrist where I have carpal tunnel. You need to identify that as a new or separate problem. You need to make sure you have a separate ICD code. You must actively manage it, but then you can break out of that global and use a 24 modifier. If you are doing a injection or procedure, you're going to use a 25 modifier. You can't use this all the time, and using a 25 modifier has a huge target on its back. You need to understand that the E&M inclusive to the injection or aspiration procedure itself includes only the discussion of risks and post-procedure management, not the workup and diagnosis of a problem. And you need to very clearly document that E&M work. And I recommend having, again, boilerplate language that separates their workup as a separate and distinct service from the procedure. Now, if somebody comes in for another trigger injection after having one before, it's hard to justify it. You want to be judicious with the use of a 25 modifier. A 57 modifier, decision for surgery, is only used for an E&M on the day before or day of surgery when it leads directly to the decision to perform that surgery. When you are doing procedures or ultrasound, you want to make sure that you document standard classic things so it doesn't get kicked out by auditors, verbal informed consent, site identified and confirmed, what skin prep or anesthesia you use, the medications you use, the needle size, how the site was localized, hemostasis, dressing, note how the patient tolerated the procedure and what their disposition was. If you're doing an ultrasound, you want to note the frequency of the probe and note that you had a permanent image retained for documentation. You need to have that documented, otherwise it will get kicked out. Same with fluoroscopy. So in summary, you need to determine whether you're going to bill directly, incident to, or split shared with an MD. This has significant repercussions for your reimbursement, as well as how this gets billed to you or the physician you're working with. Successful E&M is all about documentation. You need to learn how to use modifiers appropriately with good documentation, use templates effectively to help avoid audits and clawbacks, use CPT-based language whenever possible. And if you are consistently using cookie cutter documentation, especially when you combine it with high code levels, that is a recipe for audits and potential liability. And most importantly, with expanded scope of practice for APPs, the MD oversight no longer protects you. You have to take responsibility for your work product, and you do not get paid unless you code effectively. Thank you.
Thanks, Noah. And we'll have kind of all of our speakers can open up on video and be ready to answer questions as well. Not surprisingly, Noah, as last year, you get the opening question. They love your talks. So one of the questions that came up was, does the issue with billing for pre-op visits have a time limit when it can be billed again? For instance, their surgeon sees a patient, discusses and orders surgery at that first visit, but then the surgery doesn't schedule for several months and they pop back in for a pre-op visit, quote unquote, with the APP prior to that surgery. Is that billable?
Depends how creative you are. You know, the idea is that a third-party auditor is going to look at that and say, nope, the decision for surgery was already made, therefore you cannot bill it. And so what you need to document is that a preliminary decision for surgery was made, but the patient deferred at that time and has now had changes in his or her condition, which necessitate a reevaluation. And now the patient is reevaluated and re-indicated for surgery. That's how you get around it.
Perfect. And we got a few more minutes. So everybody enter any questions you have. Noah, kind of two related ones for you. One I struggle with is same thing with the injection code. I've been very frustrated at the lack of reimbursement sometimes for injections with the visit, as you were talking about with that modifier. Some things come up. I saw somebody 2.5 years ago and they had CMC arthritis. I injected them. Come back 2.5 years later for thumb pain. And I see them and say, we talk about all the options. We talk about surgery, and they end up deciding they want another injection. No E&M because they had a previous injection, or it's okay because we discussed everything else. They deferred surgery. Is there time limits on this? How are you documenting to get, because I think certain things are obvious for me. If someone comes in for a Xiaflex injection, I made the decision for the injection, it shouldn't be billed. If I give someone a cortisone shot and say, hey, if that wears off, come back and we'll do another cortisone. And then they come back 6 weeks later for another cortisone because it didn't take it all the way away. Those seem more obvious to me to drop the NM, but it doesn't for some of the chronic conditions. So your thoughts?
So I think that, again, it's about the way that you document. You need to introduce that patient as having had a substantive change in their condition, not just they had an injection, it wore off, now they're back, they want another injection. If you put the patient's here for another injection, or the patient wants another injection in the front piece of your note, you have then just screwed the pooch. Right? So you need to be documenting that the patient has had a substantive change in their condition. This could be a completely separate problem. So it's all about how you document that you are doing detective work to figure out what's going on. And, you know, there's some gilding the lily here, to be sure. But then you also want language showing that the injection E&M is limited to the discussion of the injection itself, its risks and benefits, and not to the evaluation of the condition itself. The patient had an E&M service that was clearly separate and distinct. The better you document that for somebody who's not medically trained and doesn't understand the context, the better off you'll be.
That's perfect. One other one that just popped in the chat said, do I understand it correctly that the pre-op H&P is part of the global? How does it work if the pre-op H&P is the initial new patient clinic visit?
So if you do a initial history and physical of a patient, if you see a new patient and you indicate them for surgery and that becomes their surgical H&P, that's a new E&M. If the surgery is that day or the next day, you would use a 57 modifier to preserve billing for that E&M and say, based on this E&M service, I made a decision for surgery. Now, if you are billing directly and the patient has already been seen by a doctor and indicated for surgery, but they happen to be coming to see you and you do a H&P the day before surgery, if you are part of the same practice as that other doctor, it doesn't matter if you're billing direct or billing incident to, that's going to get kicked out.
Perfect.
Carrie, does that answer your question? All right.
Yeah, thank you.
Well, thanks everybody for joining. I think Warren's going to do some closing statements for us, and thank you all for joining.
Yeah, I'd like to thank everybody for attending. This has been recorded and will be available on the AH website if you'd like to listen to it later. There's a lot of great pearls. I'd like to thank Dr. Gaston for moderating and all of our speakers for the outstanding presentation. So thank you for spending some time with us on a nice summer evening, and look forward to everybody joining the one next month for the second part of our series. Thank you and have a good evening.
Take care.